Well, thank you all for your patience as we get started this morning, a few minutes behind schedule, but we're so delighted that you're all here with us. Welcome again to our Global Health Compassion Rounds, which we at the Focus Area for Compassion and Ethics at an organization called the Task Force for Global Health convene with our friends and colleagues, the WHO's Global Learning Laboratory for Quality Universal Health Coverage in Geneva. The purpose of these quarterly rounds is to share our experiences, challenge ideas, and spark thinking on compassion in global health. My name is Ashley Graham, and I'm delighted to welcome you to our webinar. The theme for today's rounds is translating science into action, measuring and enhancing compassion in global health. And we really have a fantastic opportunity to understand current work to develop and implement compassion measures in healthcare and public health contexts, and importantly, to discuss real-world application of these measures and other value-based measures in efforts to enhance compassion in these settings. Today, we have three extraordinary leaders who are joining us to share their perspectives, and together we will explore and challenge our ideas about measuring compassion. And I'd just like to take a moment to reiterate a deep bow of gratitude to our panelists for joining us today, and to all of you, our participants. Our rounds are rich because you join us each quarter and you share your wonderful questions and your perspectives. And to that end, we'll be joined today by our very own Hallie Antone, who is our communications specialist at the Focus Area for Compassion and Ethics. And she's going to share with us what we learned from you all as you registered for this webinar. You may remember answering some queries as you registered and marked your calendars for this event. And it's really a wonderful opportunity for us to highlight voices from the field and really ground our conversation today in our discussion in your experiences and challenges. So, as always, we have much to cover, and let's go ahead and get started. I'd like to introduce my esteemed colleague, Dr. Sham Saeed, to introduce today's, well, actually, he's not going to introduce today's panelists. He'll kick it back over to me to do that, but he will say a quick word of hello and offer a few words of reflection from the perspective of the WHO. Shams, welcome.
Thank you so much, Ashley. And just to add my words of welcome to all colleagues who have joined this Global Health Compassion Rounds. And it is just a pleasure to have this moment with colleagues to be able to discuss in a very free and open way. Just a couple of points of emphasis. Within the work that we do on quality of care, we often emphasize that there should never be any measurement without improvement, and at the same time that there can't be any improvement without measurement. That's a go-to standard for us in terms of the measurement improvement nexus. And when we think about the work on compassion, it also needs to have that strong emphasis on measurement and improvement. For us also, we recognize that we may not have all the answers that we need to advance the work on compassion, but we have some of the answers. And that's why these Global Health Compassion Rounds are so important. We are really blessed to have some experts to be able to share their wisdom with us today. And that gives us an opportunity also to reflect what those words from those experts mean in the facilities that deliver health services. It's an important moment for us to share very openly, because there is an opportunity to shape the world a little bit further towards compassion through a focus on measuring compassion with an eye on improvement. It really is a privilege to have the colleagues with us today to be able to discuss this, and we really look forward to this moment together.
Many, many thanks, Shams, for those remarks. I'm eager to go ahead and get to our panelists, but I just want to make a quick note that I'm discovering now in real time that our chat appears to be disabled, which is not normally the case. I know many of you join us each quarter for these rounds, and we have a lively discussion in the chat. I am seeing, however, that the Q&A function is enabled, so I would encourage you to use that to make your comments and certainly submit any questions that you have. And we'll try to answer those in real time and also incorporate those comments and questions into our discussion as well. So bear with us while we try to resolve the chat function. And in the meantime, please do use the Q&A. So with that, I'd actually like to turn it over to our first panelist who's joining us today. Dr. Shane Sinclair is professor and director of the Compassion Research Lab at Advancing the Arts and Science of Compassion at the University of Calgary. He is really someone that we've collaborated with already quite a lot, and we're so thrilled that he wanted to join us today to talk a bit about his experience. A few other things to note in terms of his bio is that his recent study on sympathy, empathy, and compassion was awarded the paper of the year by Palliative Medicine. Clinically, he's a certified spiritual health practitioner, where his contributions to the field of spirituality and health were recently recognized by the Canadian Association for Spiritual Care's highest honor, their Lifetime Achievement Award. He's also the recipient of the International Psychosocial Oncology Society New Investigator Award, the Canadian Institutes for Health Research Institute of Cancer Research CAPO Award for Research Excellence, and is a former Top 40 Under 40 awardee. So I'll leave it there. I think the bio speaks for itself, but he has so much to contribute on today's round. So with that, I please welcome Dr. Shane Sinclair.
Thank you very much. I hope I am unmuted right now. I think I am. So I'm sure, Ashley, you'll let me know if that's not the case. But I just wanted to start by saying thank you so much to David and Shams and all of the people working behind the scenes in terms of offering me the opportunity to not only share some of the learnings that we have come up with here in the Compassion Research Lab, but sincerely to learn from each of you, because I think if I've learned something about compassion, it's related to action, and thinking about compassion, I think, is important, and developing measures is important as well. But I think the most important work is the work that folks like you are actually doing on the ground. So with that, hopefully you can see my slides, and I can move this out of the way. So as I mentioned, in the Compassion Research Lab, we've really been focused for the better part of a decade, actually, on understanding, first of all, what compassion is really in its truest sense. And then from that, over the last 5 or 6 years, we've been really focused on developing measures of compassion in both a meaningful way that doesn't strip compassion of its mystery and its humanity, but also in a scientifically rigorous way in order to develop evidence-based tools. So as others have said, we increasingly know that compassion is really a key to quality care. And that's something that certainly we hear from the WHO in terms of the work of its leaders. But it's something that we've really focused on first and foremost, measuring at the bedside. So I want to be clear, and a part of our discussion today and part of the learnings that I want to hear from each of you is what I'm providing is really just one gateway, if you will, into compassion. And that is obviously the patient's experiences of compassion. And I very much think and would argue that they are sort of the primary voices when it comes to measuring and evaluating and improving compassion, because they are the folks that ultimately matter. But that doesn't mean that we shouldn't be looking at developing subsequent measures that look at healthcare providers' experience of compassion within their particular organization or region, or looking at compassion at a systems level. But as I mentioned, not only myself, but others have argued that really when it comes to understanding quality care, the voice of actual patients is absolutely vital. So when we began our program of research, we actually assessed all of the available evidence related to measuring compassion. And one of the most remarkable things that we found, and this is back 6 or 7 years ago, so the landscape has certainly changed, but was the virtual absence of patients' voices in scholarship and also the development of measures of compassion. So we decided, I should say, to start with engaging patients directly, to first of all understand what compassion is through a model that we developed of patients' experiences and understanding, and then to subsequently, based on that model, to develop a valid and reliable patient-reported compassion measure. Again, with that caveat that this was really sort of the base or the foundation of building a more robust, fulsome picture of compassion that really tapped into measuring compassion at those other levels of the provider, but also in terms of a systems level, in terms of looking at the policies, the programs, the procedures, the reporting, and the delivery of equitable healthcare on a global level. But obviously you needed to start somewhere. And so our journey, as I mentioned, really did begin at the bedside to determine, first of all, whether we could actually measure compassion. Is that something that we can actually do? And second of all, we really wanted to assess the evidence of existing compassion measures. So what we discovered in this systematic review that we did looking at compassion measures is that, number one, yes, you can in fact meaningfully and scientifically rigorously measure compassion. And number two, unfortunately, at the time, we also discovered that there were some fairly significant limitations in terms of the scientific rigor associated with these existing compassion measures. So how did we determine this? Well, we determined this by using a valid and reliable tool for evaluating the measurement of patient-reported outcomes. So the MPRO is the tool that we use, which is basically kind of like a report card of the key properties related to patient-reported measures. And so the results, as you can see here, indicated that at the time, there were no sufficiently robust, valid, and reliable patient-reported measures of compassion. And again, this was based on sort of those established metrics that we all know are important when it comes to assessing the validity and reliability of a scale. Number one, is it valid? Does it actually measure what it reputedly is saying that it is measuring? Is it valid? Is it something that you can apply on an ongoing basis? Is it dependable? Is it responsive? And so again, the cumulative or the kind of total results, as you can see here, really left much to be desired, not only in terms of 32 out of 100, really in many ways actually being quite remarkably mirroring my junior high school report card in a number of subjects, just to confess a little bit in terms of my background. But as you can see, that's not something that we necessarily feel a great amount of confidence as measure developers. And so as a result of this, there was a number of limitations. Just very briefly in the time that I have, one of them was most of these measures were actually healthcare provider self-reports. So it was people like me going into a room trying to offer compassion to a patient, and then I would come out and evaluate how compassionate I was. So obviously that's a big difference from the patient's experience of compassion, which might actually be very different. And as a result of this, what was often produced not only had poor psychometric properties, but really amounted to what I would say was a series of checkbox or ticky boxes that seem to assess things like this. The cartoon there says, "Of course I'm listening to your expression of suffering. Don't you see me making eye contact, striking an open posture, engaging in supportive touch, and leaning towards you and nodding empathetically?" So many of these measures kind of eroded compassion down to what I would argue is a series of clinical transactions or behaviors that helped healthcare providers perhaps to be perceived as compassionate, what I would refer to as, virtue signaling or contrived compassion, if there is such a thing. But basically, that's what those measures seem to be looking at, whether healthcare providers sat versus they stood, and some of these things that are, I think, referred to here in this cartoon. So over 4 years, we developed a methodologically rigorous and meaningful patient-reported compassion measure to measure compassion in patient care. And across all stages of development, we really inserted the patient's voice to make sure that we did not veer from their experiences. So after validating this with over 700 patients, we now have a 15-question patient-reported compassion measure called the SEQ. Which we also know now is the most valid and reliable patient-reported compassion measure that is available. And so we've really addressed many of the limitations, most of the limitations that we had with those previous things. So importantly, when it comes to developing measures, we never sort of arrive at, a final position of validity and reliability. It's an ongoing process. So we are in the process of actually making sure that, number one, this measure actually works across other patient populations, because it was developed in acute care, hospice, and long-term care, but we are now conducting studies looking at emergency departments, primary care, and outpatient settings. But I think importantly, specifically, I want to emphasize for this audience is the need to validate the transferability of this measure in other languages, and importantly, not just translating into other languages, but ensuring that it actually is valid in other populations, regions, and contexts. Because if history has told us, one thing, we should be very, very careful about simply applying a Western, developed compassion measure into other regions of the world. So we need to work with people like you to really make sure that this has legs. I think I have a couple more minutes left, Ashley, although I'm probably pressing my limits there. I just wanted to give folks a little bit of an application of this measure. So again, while it's primarily for research, in clinical care, as an example, we can see here that this is a patient that the SEQ was administered to a week ago, and again was administered again this week. And what this allows clinical teams to do is to really dial in and to look at this as they would, other kind of vital signs on a routine basis, and to assess, are there changes from one time point to the other? So as we can see here on this first page, there's nothing remarkable in terms of changes. But as we come to sort of the last portion of the SEQ, we can see here a week ago that this patient felt that his healthcare providers really understood his needs, and they really were able to see things from his perspective. But as you can see here, today, this morning, those two items have actually dropped off in a pretty significant, a clinically significant kind of a way. So this allows those teams to kind of, first of all, be able to assess something that they normally wouldn't have been able to assess. So it just would have gone unnoticed. But they could actually go back and either meet as a team and say what's going on here, or actually use this as a conversation starter with that patient and say, compassion is important to us. We've noticed some things dropping. In the minute that I have left, I'll just say at a systems level, I think this could also be utilized to identify benchmarks and really to analyze associations. So for example, in one care setting that had the same patient population, same sort of demographics, same services available, we can see that there's lower patient complaints, better patient outcomes, and less patient safety instances in comparison to hospital B. And I think this measure would allow us to really see how compassion is a factor in those things, because we actually know that compassion has been demonstrated as a factor in terms of lower patient complaints, overall patient satisfaction. So if we were to use it on a systems level, it would allow us to actually begin to tap into how important compassion is on those sort of more standard metrics. So I'm going to sort of pause there in terms of my time, and I'm going to pass the baton back to either Shams or Ashley or someone else to hand it over to our other panelists who I'm very interested in hearing from.
Wonderful, Shane. Happy to give you a few extra minutes. Thank you so much for that presentation. And I think it's It's so valuable because as we were preparing for this rounds, so many questions were, what are measures of compassion? What do they look like? And so you've really been able to shed some light for us on what a measure would look like and what outcomes you may be looking at. So we're going to transition now into our next panelist presentation. We have with us today Dr. Chintan Maru, who is Managing Director of the Global Development Incubator and CEO and founder of Leapfrog to Value. So just a few words about Dr. Maru. He believes that health systems should promote not only physical well-being, but also human flourishing. As CEO and co-founder of Leapfrog to Value, which is a platform advancing the field of value-based care in India, South Africa, Ghana, Kenya, and beyond. He's also managing director of the Global Development Incubator, as I mentioned at the outset, where he has built a portfolio of initiatives focused on improving health systems. Prior to founding Leapfrog to Value, he was a consultant in McKinsey & Company's health systems practice, where he led value-based care reforms for payers, providers, and state governments in the United States, and advised on public sector delivery transformations in Africa. He co-wrote a report for WHO and PAHO on financing primary care in Latin America. He's a graduate of Johns Hopkins School of Medicine, a former public policy and international affairs fellow at Princeton University, and a Fulbright Scholar of Jamaica. And he's an undergraduate from Duke University, which I won't hold against him as a UNC grad. And I'm still looking forward to hearing what he has to say about his tremendous work related to value-based metrics. So Dr. Maru, please take the floor.
Great, thanks so much. And I think Patricia may be sharing some slides. The question that I wanted to sort of start with is, we talk about compassionate health systems because we care about compassion because it touches some deep chord in our humanity. It also, perhaps, has some instrumental uses in that they may deliver better outcomes. Compassionate health systems may deliver better health outcomes and also potentially could become a better buy as we think about financing UHC. And so I want to sort of think about measurement of compassion with that frame in mind. You can sort of advance, please. And I'd like to sort of explore this just through a concrete example, the TB work that we're engaged in India. TB is interesting because it's a case in point for something that we observe across the world, that spending more on healthcare doesn't necessarily buy you better health. It turns out in the same 5-year period where spending doubled on TB care in India, outcomes actually got worse. Mortality from TB doubled, treatment completion dropped. And this chart captures really the underlying problem that we lose patients at every step in the journey. And so we started asking, why is that? Scroll down. We asked frontline providers this question, and they say that they are asked to play a numbers game, crank as many patients as you can through the system. And they say that they don't have the time or resources to address patients' complaints, emotional stress from a diagnosis, side effects of a drug, loss of work, worry that they'll infect another family member. And patients echo this. They want and need human-centered care that they're not getting. They don't feel heard, don't feel treated with dignity. And you could call it a trust problem. You can float down. And so USAID India mission invited us to apply our method to this problem. And the approach really aligns patients, payers, and providers around a common goal, achieving outcomes that matter to patients at the optimal cost. And so we embed that thinking in how we measure care, how we deliver care, and how we pay or finance care. And I want to sort of share how we applied this to TB, really emphasizing this measure piece of this triangle. And so, as many of you know, directly observed therapy has been the standard approach to TB care, or DOTS. And so imagine in that context, a healthcare worker literally watching you take watching you take every T-bill you take for 6 to 9 months. There's been tremendous focus on the middle circle here, treatment completion, but that doesn't meaningfully address other patient concerns. So we designed and launched a pilot to take a more human-centered approach, addressing care experience and quality of life. What does that mean? So instead of that traditional DOT approach, patients have a choice on how to track their meds, usually using digital tech at home to track their meds at home. We screen patients for depression and anxiety and offer counseling for those who want it. A patient is eligible for a cash, if a patient is eligible for a cash transfer, we help navigate that. If a patient has a side effect, staff takes the time to talk through it. And so this schematic on the page really shows how the traditional model in light blue and how these other elements fit together. In that traditional model, the focus on care seeking and treatment completion, as the theory goes, will really get you that end clinical goal of recurrence-free survival. Whereas our thesis is that improving care experience, quality of life will keep patients better engaged and ultimately lead to better survival rates. And so we don't routinely use the word compassion, but this more holistic approach to measuring and improving outcomes is meant to be just that. And each arrow in this diagram really represents a hypothesis. Does improving one really improve the other? And so we've developed a method of routinely measuring these to help test these hypotheses in these public TB programs in Gujarat and Jharkhand in India with both patient-reported outcome measures and patient-reported experience measures. Want to go to the next page, which has a second part of the hypothesis that these investments in a more human-centered approach may actually have a payoff. So that we know that bad outcomes cost us dearly, that households pay out of pocket for some healthcare and lose wages. Governments and donors bear the cost of expensive second-line drugs, hospitalizations that may occur with complications. So if we invest in quality of life, in care experience, in addressing social determinants, we believe we can reduce the costs associated with bad outcomes and deliver better value to patients and to payers. And frankly, it's not a unique observation. The barrier in TB is similar to many other areas, that there's really little visibility or accountability for costs across the patient journey. Where you've got donors paying for drugs, for example, maybe states paying for personnel costs, households paying for some stuff out of pocket. But if you look at from the provider perspective, if a provider is offering compassionate human-centered care and that provider's patients don't develop drug-resistant TB, that person may be saving money for the system, reducing these sort of costly second-line meds, for example, but the government doesn't have any way to channel patients to those higher-performing providers. There's no incentive or recognition for those providers for being better stewards of resources. So in this work, we're really measuring longitudinal costs, following patient journeys to understand what is that performance threshold at which human-centered care is cost neutral or even cost saving. And essentially, we want to understand that core question of whether compassionate care can deliver better outcomes and is it ultimately a better buy. I just want to close on a few, three really questions or lessons that are coming out of some of our implementation. The first is around expectations and trust. Many of our patients have low expectations. And we found that they'll often give a high rating on care experience, whether or not it's deserved. And it's exacerbated when patients don't have choice on where to seek care. So it raises a question for us that we haven't solved. Would love to hear your thoughts on how do you raise expectations so you can get more meaningful feedback in that context where there may not be that much choice. And there's a trust element too there, which is if you ask about care experience, you receive negative feedback and don't act on it, you can actually erode trust. So be careful if you're just doing this for research purposes. The second question is around cost. So measuring these, as you can imagine, is an investment, cost time, patient time, caregiver time, and that can really take away time and attention from the compassionate care itself. Yet, if we make the surveys too brief or infrequent, they don't give us adequate insight. So there's a trade-off there that we're grappling with. And the third is around intrinsic will. There's a sort of body of behavioral psychology that tells us, warns us really, that incentives can erode intrinsic will to do the right thing. So if you start measuring compassion and then add accountability or financial incentives around that, are we actually cheapening a sacred relationship between patients and their healers? And yet, again, paradox, if we don't measure and have accountability, and if we don't allocate resources around that to do the right thing, will we get the results? Another sort of, so three sort of thorny questions to end on. Thank you.
Excellent. Thank you very much, Chintan. Wonderful presentation and really eye-opening as well. I think as we were leading into these rounds or this particular rounds, we had questions about cost effectiveness and making a business case for compassionate care. And so I think you've given us a lot of food for thought, and I'm hoping we'll have time to return to that in our discussion as well. So now I'd like to turn to our third and final panelist, Dr. Ian Spillman, who's joining us from Wales in the UK. A few words about Dr. Spillman. He actually worked in the NHS until about 1987, when he and his wife, Hannah, a midwife, moved to Southwest Uganda to work with the Tear Fund at the Church of Uganda Kisizi Hospital. After 6 years at Kisizi, he subsequently worked as a consultant pediatrician back in the UK, where he developed Streamline, which I know he'll probably speak more to today, a patient-centered electronic medical record IT system. Returning to Kisizi in 2012, Dr. Spillman then spent 10 years there as a medical superintendent and pediatrician. And while at Kisizi, he further developed Streamline, this IT system, incorporating key patient safety features highlighted by the WHO African Partnerships for Patient Safety program, and integrating a health insurance module, patient finances, procurement, stock control, etc. Streamline has since been rolled out to 38 hospitals and clinics in Uganda and has just won first prize in the 2022 Swiss Ari Foundation for Resilience Award, which will allow expansion of community health insurance to many more vulnerable communities. Dr. Spillman also contributed to the development of the recently launched WHO Quality Toolkit, which many of you may have seen us publicize on social media as well. And with that, I'd like to turn to you, Dr. Ian Spillman. Please join us and look forward to your presentation.
Thank you so much, Ashley. I'm going to share screen. Hello, everyone. I should be trying to find my, just let me find my slides. Okay, I need to just, problem with what I can see. Can you see my slides? Oh yeah, here we are. Thank you. Right, can you see and hear me?
Yes, you're all set.
Good. Okay, so we live in a world of difference, and we're all aware of the huge discrepancy in healthcare allocation and availability. But the good news is we can make a world of difference with compassion. Desmond Tutu talked about the fact that love and compassion are often seen as sentimental, but in fact, they're very demanding. And if we're going to be compassionate, we must be prepared for action. And I think that my colleagues have already emphasized action is so key. So I'm going to take you to Kisizi in Southwest Uganda and share some initiatives there. You come about an hour from the tarmac road into the Southwest to a busy hospital serving mainly subsistence farmers. And we have a beautiful waterfall. And the motto of the hospital is life in all its fullness. And that is really part of the story of compassion, which summarizes holistic care We're interested in health of the whole person. We're interested in the body, mind, spirit, and community. So different dimensions of health are our goal when we're giving compassionate care. But I would suggest there's another dimension, that compassion is four-dimensional, because I think time is also important. Now, for example, if we have a patient coming to us at 3 o'clock in the morning, is the quality and the compassion that they receive the same as if they came at 3 in the afternoon? And if we're going to measure compassion, we need to think about these aspects too, because they make a difference. As Sham said at the beginning, there's no point in measuring if it doesn't lead to improvement. So we need to think about these real world issues. And also, are we interested only in the current well-being of our patient or their future well-being too? So different dimensions of compassion in practice. And I'm going to show you one of my patients who came in moribund in a terrible state with a hemoglobin of only 2.1 with serious sepsis. And this was because he had been to a traditional healer in the community, and they had tried to remove his unerupted milk teeth, which is one of the local practices for treatment of gastroenteritis. So what is the compassionate response to such a case? Well, of course, we work really hard all night, stabilizing this child, transfusing and treating the acute medical problems. But the compassionate response is more than that, because it also involves going out into the community to try and prevent this happening to any other children. So there are various dimensions to compassionate care. And if we're going to measure them, we have to think at system level as well as individual patient contact. So I'd like to introduce you to Kente and her mother. And she came to us with coughing and a fever, a common presentation. So how does compassion look in this scenario? And I think if I asked that question, many people would go to the compassion equation and would talk about the need to be aware of suffering, and then a desire to do something about it, and then taking action to deal with the problem. But this question of being aware of suffering requires a little bit of effort. And I think if we look at this, we would say that we should be taking a really careful history. We should do any appropriate health screening. We should thoroughly examine this patient, and we should do appropriate investigations. And all of those together that will then lead to synthesis, which then helps us to draw up a detailed, holistic action plan. Now, in Kente's case, yes, she had severe pneumonia and was treated with IV antibiotics as per the protocol. But we also, in the careful history, noted she had an incomplete immunization and she had missed measles vaccine, which threatened her health in the future. And so one of the action points was to deal with that. We noticed that she had a younger sibling, and mother was really struggling with young children and needed some counseling and support for family planning. And we discovered father had an alcohol problem, and we were able to give local language information and support, which could reduce the risk of the whole family being affected in the future. Kente had borderline malnutrition, and we could give education and demonstration to try to help her avoid tipping down into more serious malnutrition. And examination revealed dental caries were reviewed and advice given. So important, because his life in all its fullness, then all of those issues could detract from wholeness of body, mind, spirit, and community. So when we come to measure and evaluate, we would ask, are all the issues recognized, and is with the cough in the child, that's what I've come with and that's what you deal with. These other areas may be missed, but actually a compassionate approach will want the best for the whole person. So in Kasisi, we have weekly multidisciplinary audits for all of our staff, and we discuss cases in this way, and that interaction is really helpful. I think in the questionnaires from patients and in self-reporting, you lose some of the interaction which a multidisciplinary system can give you. And our expectation on ward rounds and CPD and everything else is that we embed compassion in everyday practice, We're dealing with people, not just cases. And that's embedded in our School of Nursing and Midwifery, whose emblem is compassion and competence. So we have a multidisciplinary team who exhibit compassion, and part of the team are the chaplains and the counsellors from Hope Ministries. The rehab, palliative care and clinical teams are all working to bring compassion. And I think one of the key things is that compassion is to be given in institutions by teams. And I liked Shane's questionnaire that it asked the question about healthcare providers in plural, because it recognized that it's a team approach. Interestingly, in the NHS, some work on primary care chaplaincy showed that when it was compared with patients receiving antidepressants, the outcomes in terms of well-being improvement were the same. This was attributed to listening with generosity of time, spiritual direction, and compassionate presence. And interestingly, in the chaplaincy group, less follow-up appointments with general practice were needed. Is that a measure of compassion? Here's Asimwe, who presented with edematous malnutrition, and here he is about a week later after much improvement. But you'll notice he's wearing the same shirt and hat, and that's because that's his only shirt. And it reflects the underlying problem being poverty. So part of the compassionate response is not just to get him better, but also to try and stop him relapsing in the future. And we did that with things like a demonstration garden so that the family learn how to improve the diet. And we set up this garden not only in Kisisi, but we also put the same thing into different places, in the very places from which we've received the malnourished children, trying to prevent in the future. I would suggest that's a compassionate response, and we can measure a little bit how many children come from those villages in the future. We make ready-to-use therapeutic feed to try to keep these children in good health. And we have goat and chicken projects which support the really poor families with a goat or chicken, and that can be a life-changing intervention. So what I'm trying to show is system-wide compassion in lots of different dimensions that transforms lives and really makes a difference, with root cause analysis and then taking appropriate action. We have a child sponsorship program, particularly for orphans, and we have a Good Samaritan Fund that supports those who have struggled to pay their health bills. Because finance is such a key area, the Community Health Insurance Scheme is the oldest in Uganda, and it was a not-for-profit system engaging the community with the motto, affordable access to quality health care. And this whole scheme was motivated by compassion because there was a recognition of the community suffering and a practical action taken to address it. It was recorded in the Economist magazine, who noted that the insured are healthier and their finances are too. And we currently have around 40,000 beneficiaries in about 220 different community groups. And here are some of the leaders of those groups meeting together. And we found this a really valuable channel for patient satisfaction feedback. One of the problems if you do surveys in the hospital setting is that it may bias the patients, because if the survey is being done while I'm in hospital, I may be worried that if I make any negative comments, it may affect my care. But if we do it in the community setting, it's after a time of reflection, and it can be quite useful. Now, one of the really exciting things as a pediatrician is that in addition to financial protection against catastrophic health expenditure, we've demonstrated a dramatic improvement in childhood stunting. A year more than 5% reduction. Is this a measure of compassion? We also demonstrated, to our surprise, that the admission rate of patients belonging to our scheme was only 50% that of non-scheme members. And we believe this is actually an example of universal health coverage in action, and it's a marker of compassion producing fruit. Our Mother's Waiting Home was started for a number of reasons, including a tragedy in 2012 when 2 mothers arrived in Kisisi already dead because they just could not access our services time. Such a terrible tragedy in our business, but also to set up a 24-bed mother's waiting home to avoid the problem in the future, to give a place of refuge where the mothers are cared for by a midwife every day and a consultant every week and can be safe. In our mental health service, the Ahamusa Center, we see patients sometimes coming in with serious mental illness. This was Stephen, who'd been shackled for 8 years, and here he is now recovered and with a good quality of life, speaking on a TV documentary. Now, we've been able to then ask the question, can you use IT to help maintain, is it a compassionate response to such patients? And we found that by integrating some research findings from the Emerald program, we're better able to monitor the well-being of such patients going forward. And Streamline, the IT system we've developed in Kisisi, does a whole range of different things, but we believe it can enhance compassion. For example, in triage, not only does it have patient safety features like the ETAP WHO tool, but it also always integrates health screening. And so patients who come always are checked for alcohol, tobacco, family planning need, tuberculosis, and body mass index, trying to look more holistically at their needs rather than just the one thing that they maybe have presented with. All of our patients traditionally used to receive their medicines in these plastic sachets, and somebody would have just written in ballpoint pen. Now the system produces something with a personalized label in the language of the patient so they can understand it. Now, I was interested that I think Chin was talking about TB and about drug-resistant TB. This particular example is rifampicin, and every patient receiving that drug gets this message which says that their urine may turn red. If they haven't had that message, they may stop taking the drug because of they're worried that it's blood, but the message itself can communicate, which is a good patient safety thing, but it's also showing respect and respond to their issue and their own suffering. So we've just won this prize, which is going to help us take it out to 150,000 more beneficiaries in the next 2 years in 15 different centres. And we believe that compassion really can make a world of difference. I've just scratched the surface on a number of areas, but thank you so much for listening and handing back to Ashley. Thank you.
Wonderful, Ian. Thank you very much for your presentation. And as you all who are attending the webinar can see, we recruited these 3 panelists because they offer such different but related perspectives. And I think this final perspective you've just shared, Ian, is crucial as we ground our thinking in what is it we're measuring and for what purpose. So with that, I would like to just take a pause on the reflections that our panelists have shared, and we will return back to them very shortly. And in the interim, I'd like to invite my colleague, our communications coordinator in our program at the Focus Area for Compassion and Ethics, Hallie Antone, to just give us a bit of a presentation on what we learned from all of you as you registered for the rounds to further ground our conversation in your perspectives and your voices. Hallie, please join us.
Hi, everybody. Patricia, if you wouldn't mind sharing your screen. Thank you. So as you may recall, when registering for this Global Health Compassion Round, we asked you guys to answer a few questions, and we wanted to take some time to share your voices. Next. So we learned that from many of you, the organizations or the workplaces that you're a part of bring compassion into the day-to-day practice in various ways. Some of those ways may include emphasis on self-compassion and self-reflection, as well as highlighting the importance of inter-colleague care. Other places offer compassion trainings. Some offer staff huddles and mechanisms for feedback. Others are also good about allowing for a space to share individual stories or prioritization of co-creation and patient values. And some organizations focus on creating a welcoming environment where everyone is treated with respect and dignity, and each patient is cared for as a whole, including their financial status. Give you guys a few seconds just to look over all of them. And no worries, it's important to note that many of you also mentioned the that these efforts are all driven by strong leadership, that this is key in the compassion day-to-day practice. Next, please. And here are some specific examples from you on how your organizations bring compassion into the day-to-day. Two of my favorite quotes came from colleagues from Bangladesh and Canada. I'm just going to read those out to you. Our colleague from Bangladesh states that listening to colleagues, encouraging them to speak up, share more, giving them space to share. And our colleague from Canada, reminders to practice self-care. I chose these two because I think in order for our healthcare workers to care for others, they have to first care for themselves. And in order to encourage compassion, we have to allow for a space where our colleagues can speak up and they feel safe speaking up in these spaces. Just give you a few more seconds just to look over the other ones. And next, please. And we also asked you about some of the challenges you face maintaining and enhancing compassion at your work. And we found that the most recurring answers were burnout, as there are pressures in terms of time, workload, resources, staffing. This was heavily emphasized, as well as limited compassionate leadership within the organization and organizational support in general. We also saw that there was limited awareness of the importance of self-compassion and self-care. There was less focus of the internal expressions of compassion. So it was more so focused on your patients. It's less about the healthcare worker themselves, which makes it very difficult when you have to take care of yourself initially before you take care of others. And another challenge that we saw was empathic distress. So there was a lot of emotional experiences, as well as witnessing unethical practice and individual suffering not included in metrics that measure success at population level. Just give me a few seconds. Next, please. Thank you. And some specific examples of challenges from you are listed here, and a few that I thought were important to highlight were from our colleagues from Sierra Leone and Malaysia. Our colleague from Sierra Leone stated that local healthcare workers receive no pay, which leaves them less compassionate and unmotivated. And our colleague from Malaysia states they are overworked, staff attitudes, and high turnover. I thought these were particularly important because when local healthcare workers receive no pay, it's very difficult for them to be motivated to come to work and give everything they have to the people that they're serving, because they're getting nothing in return. They're being worked to the ground. And then in terms of Malaysia, I thought it's really important as well. Like when you're overworking the people who are supposed to help you, it's very difficult for them to want to stay at the job that they're at and to continue to help these people. So it creates a lot of gaps within the healthcare workforce and creates a high turnover. Give you a second to read the others. Next, please, Patricia. And it was clear that you all had many questions on compassion metrics. So we tried to compile it into these few questions. I'm just going to list them out. So some of the questions that you guys asked were, what measures are available for us? What practical approaches for enhancing compassion are there? Are there any measures for different contexts and levels of global health, like organizational, community, and population, as well as cross-cultural? How to get guidance for incorporating these multicultural or diverse perspectives? And what's the business case for compassion? What role do these donors have? Is it beneficial for them financially? And what's the downside of measuring compassion? Is it reductionist? What is the loss? Is it artificial? The fact that we have to put so much emphasis on it doesn't mean that it's actually true to heart to us. And we also asked the question about it being objective and subjective measures. There were more questions on, are there measures based on patients' expressed needs, and how to incorporate compassion measures into existing monitoring and evaluation efforts. And I understand these are only a few of the questions we received from the responses when registering, but if you do have any other questions, please feel free to put them in the chat or in the Q&A section so that they can be addressed by our panelists. Thank you.
Thank you very much, Hallie. It's I'm so delighted that you agreed to present the voices from the field. So many times in webinars like this, there are many colleagues with incredible amount of years of experience and not enough youthful voices and youthful perspectives. And so thank you so much for joining us and being part of our webinar today. And as Holly indicated, we received many different questions and responses, and we just tried to distill those into those that really rose to the top and highlight some of those for you. I'm really looking forward to digging into some of those questions in our discussion. And so we will move now into a panel discussion with our panelists, where we'll have the opportunity to sink our teeth into some of those questions, as well as some of the ones that are coming into you all. What I'd like to do, though, just because it is so important for us to ground our thinking on compassion measurement in real world application and in the experiences and the voices of the field, some of which Holly's just shared with us, I wonder if I might invite you all to maybe just give us a word of reaction to some of what you heard in the section that Holly just presented, in terms of the kinds of efforts that are ongoing, the challenges that different organizations and individuals are encountering with implementing compassion, and also some of those questions that have come up. Any sort of initial reflections, I suppose, on those voices that have been shared. And Ian, I'd like to start with you, and then we'll go around from there. Oh, Ian, you're muted. No worries.
Yeah, thank you so much. I think one of the key things that's coming through is the working as teams. And I think it's true that particularly in acute care, there's often the queues can be long, the conditions can be serious, and having teams that share out different roles can really work. So I think I noticed some of the things Holly was saying where people were talking about long hours and being sort of stressed by the demands, and we're not only trying to be compassionate, we're also trying to be efficient, we're also trying to have high quality and so on. So I think if we have teams that are motivated and working well together, so I liked her first slide where somebody had said that they start the week together and they sort of take their breath and they presumably have feedback, and it sets the scene, and then everybody goes out as footballers to a match might go, motivated to pull and to work together to support each other, and then you don't feel so isolated. I think some of the complaints seem to be isolation, so that would be one comment. Thank you.
Thank you, Ian. Chintan, any thoughts or reflections?
Yeah, the headline for me around burnout under resource health systems is what encourages me to really figure out if there is a payoff. Like in some ways, it's maybe the more mundane thing, which is looking at compassion not for its like beauty, but for its instrumental reasons. But if we want to unlock the resources to really to give staff the space, time, resources to be who they want to be in the work setting, then we might need to go back to these payers, to the people that allocate resources to make the case for it.
Absolutely. Thanks, Chintan. Shane.
Just picking up, I think, on some of the things that have already been said, but one of the things that stuck out was just around sort of a systems approach. I think we saw the burnout and mentions around self-care, and it just reminded me all of those things I think are incredibly valuable. We need to be taking care of ourselves in order to be able to, to use Ian's analogy, you need to be practicing in order to be game ready, so to speak. But I think there's a bit of a short-sightedness sometimes in that of, we're going to sort of subcontract the compassion out to the individual healthcare provider, that it's about them taking care of themselves. And there's a level of, I think, shame and potentially blame that comes with that, of like, if you're just better at self-compassion, things would be better for not only patients, but for the entire system. And I think that, again, is essential. I don't want to be misquoted on that, but if we're not creating the conditions where compassion can flourish, and we're sending people out with, in environments where that isn't something that's espoused by leadership. Again, I think we saw that a lot in the COVID times here, certainly in Canada, of sort of like, just be resilient. We're going to feed you muffins, and we're going to come in and encourage you and coach you to just dig down deep. And I think what I've heard from not only Chin, but also from Ian and many of the people that are connected to this, is that that again can be a little bit short-sighted in terms of putting out little fires where we don't have sprinklers in the larger healthcare system, but we expect firemen and women to be putting those fires out. So I really appreciate the more sort of global system level approach to this conversation that I'm hearing from everyone.
Can I throw in one more comment here, Ashley?
Please do.
This thing about not having enough resources is so serious. I don't want to take it lightly, just like, oh, come up with a business case and everything going to happen. But there are some creative solutions. There's a group called Noora, Noora, for example, that is working with family caregivers who may have traveled, show up at a health facility. How do you enable those family members and kind of give them the tools to participate in care? Could that make a health system more compassionate and actually tap into resources that are kind of latent and not really recognized? And so I think there's also a lot of room for creativity in addressing this sort of like not thinking too much from a scarcity mindset, like find the abundance of compassion that might be in a society regardless.
Absolutely. I've had conversations with others, and the words of a former colleague from Bulgaria stick with me. And she said, compassion needs to be treated as a resource in and of itself. I think that you're all hitting the nail on the head, certainly in connecting to what rose to the top from our voices from the field in terms of burnout and self-care, and so often the onus is placed on the individual to be resilient, as you said, Shane, even though they're operating within a system that is so challenging and potentially toxic. That how sustainable really is that? And so I suppose I appreciate your example, Chintan, in terms of thinking creatively about solutions. But I wonder, and I'll kick this to you to start, Chintan, in terms of, you spoke a lot in your presentation about the cost effectiveness and sort of thinking at that level, but oftentimes we hear things from people in the field like, how do I foster buy-in from my leadership as a barrier as well? And certainly the financial piece is one angle, but I just wonder if you might speak at all to other ways when you're thinking about enhancing compassion at a systems level to creatively fostering buy-in from leadership and the organization itself.
Yeah, I'll answer this briefly and pass to others. Our process always starts with bringing that triumvirate together: patient advocates, frontline providers, and payers. And those payers are, whether it's a health insurance scheme or government payers. And I think the rationale for the patient and the provider are pretty obvious. And maybe the one that's less expected is the payer. And it's really about what are the questions that become barriers to resourcing health systems appropriately so that they could deliver a more human-centered approach. And so how can those three groups collectively define value, the outcomes that matter to patients, and then including compassion and then the cost to achieve those.
Excellent. Yeah, and I so appreciate the inclusion of patient advocates in that triumvirate. One of the questions we received from a person who's participating today was thinking about expressed patient values. So are those things being taken into account as you're thinking about measuring compassion? Ian, I invite you to also provide your response in terms of how to foster buy-in to enhancing compassionate care.
Well, I think in institutions, it immediately asks the question, what are the key values and aims of the institution? I told you in Kasisi, it's life in all its fullness is the goal, which is just 5 words, but it's so broad, it really helps because achieving that is trying to sort of put compassion into practice, and it has so many different aspects, and that's why measuring it, I think one of the key things is one size doesn't fit all, because there are so many different dimensions. But the engagement, and I think the sense of working together to achieve it, we've been very excited. I talked a bit about the insurance scheme. That has had no outside donor input until, in fact, this new grant we've got is a new dimension. But up until now, we've not had any donor support for that scheme. And the premiums are only between 3.5 and $5 a year for acute healthcare. So the community have come together and are engaged with that. So then those sorts of schemes are then, there's a lot of motivation to make it work. And the feedback is honest when it comes. The other thing about any feedback is always making sure that people see that you respond to it, that you actually take action in response to what has been shared, because that then encourages people the next time. So in our multidisciplinary meetings every week, all of the staff come together from different disciplines and discuss not just statistics, but also particular cases or incidents. And that's really been very fruitful in lots of ways. We all learn from each other, but it also gives that a holistic approach has been taken. So yeah, lots of things like that can be motivational. Thank you.
Thank you, Ian. Shane, any thoughts?
I always have a lot of thoughts, and some of them are well formulated, but a lot of them are lingering questions that I haven't found answers for yet. But I think that's what this conversation's about. Just off the top of my head, I mean, I do think, you know, I'm not a believer in this sort of the saying of like, unless you measure it, it doesn't exist, or, you know, that's something I think is a little bit too strong in my opinion. But I do think measuring it provides some teeth and some meat to the bone. And so I think, you know, whether it's measuring it for the sakes of funding, you know, with senior leaders, that it's sort of connected in some way, that we're measuring quality care, the patient experience, compassion. And it's not simply sort of this, I don't know, an optional extra that we just sort of add on, but that it actually is connected to, for example, in the US hospital ratings, insurance, and those sort of things, whatever systems we work in, that the way in which we deliver care is as important as the types of, you know, services and those sort of issues. So I do think we need to, there needs to be a level of measure and accountability, that if we really, really take the patient's voice, as Ian was saying, to heart, it goes all the way up from that individual practitioner to actually a systems level. I also think there is something around, to Chin's point as well, and I'm not a fan of like rewarding and recognizing compassion. I think the second part of that, I like the recognizing piece, but the idea that like, you know, you did a good service to somebody, we'll pay you, you know, a little bit more, I think sort of takes away from the whole heart and genuineness of what compassion is. But I think there is a need for us, whether it's in performance reviews or whether it's in, you know, supervisory sort of meetings. If compassion's important, we need to be able to recognize those individuals, because what we know from research is that when you don't recognize it, you are in fact sending a message. You're saying it doesn't matter what you just did. And so again, I think there are ways to include those types of things if we do value them, in terms of you know, individual one-on-one sort of, I don't even want to say, you know, performance measurement, because but if we're not asking those things, we're not concerned about them, I think we are sending a pretty strong message. So those are a couple things that come to my mind.
Yeah, I was going to invite you to respond, Chintan. Go ahead.
Yeah, we do pay for things. And so I think the question is, what should we pay for? We pay for stuff that we measure. So right now, the Indian government runs what's meant to be, you know, one of the largest, if not the largest, health insurance scheme in the world. And it's essentially a fee-for-service scheme. And so we're paying by the volume of healthcare services rather than the outcomes. achieved. And so would you rather a system pay for and reward providers for the number of healthcare services it churns out, or whether the health system is achieving that patients say they've achieved the outcomes I want? And the outcomes not just being compassion, but this holistic set of measures of the clinical outcomes, the quality of life and the care experience. I would say, yes, it does. There is that risk that it would cheapen things, but would you rather pay for just volume of services?
Well,
I'd pay for both. You know, like I'm a tough sell. I'd want to see that, and maybe that's a little bit idealistic, but I think, you know, it's not just. It is about receiving compassionate care, you know, at the bedside. But when you're talking about volume of service, I think sometimes we can kind of look at that in a very negative way and say it's just about numbers. But if I'm that patient who, you know, needs that particular service, I do care about volume of service, and I do care about being able to access those things. So again, I think, you know, in fairness, I probably in researching this have way more questions now than I did 10 years ago. And obviously the answer that I provided you, Chin, was, you know, kind of a, maybe not an impossible one, but I think it really does sort of show that the challenges that it's not only getting in the door where compassion starts, it's also the access, the volume of how you find your way into those things. So if we turn off the volume tap, if you will, you know, maybe the quality would rise up, but there'd be more people suffering on the outside of our hospital, for example. So again, a conundrum that I probably just want to acknowledge more than anything, but something that I'm sure by the end of the day, Chin, you'll figure out and be able to solve for us. I know it's impossible, but.
Well, I so appreciate we are seeing in real time the challenge component of our compassion rounds, and really sort of challenging our own thinking, which I so appreciate the fact that the two of you are able to engage in that dialogue. But I will say that one of the things I think that is important for us to consider, and what Shane, I believe, was flagging in his comment or his you know, critique, if you could call it as such, is what's the downside of measuring compassion in this way. And Ian, I'd like to start with you there and see if we might go around the table.
Yeah, we have to always look at what tool is used and how it's administered. So for example, I really liked Shane's questionnaire, and I liked the idea of it being repeated. I thought that was very interesting. I think my question would be, who's administering it? So if I'm a patient on the ward, who is the one asking me the questions, and whether the person asking may influence how I react. When we've tried to do this in Kisisi, we've tried to use teachers from the primary school who are not involved in the clinical side at all, or we've used retired nurses who are respected in the community, have been useful people who will trying to get an objective answer. So I think the way the test is done and what you're actually measuring is important. But then obviously the questions are quite broad as to whether you felt overall cared for. And I think that goes back to, I think Chin was talking about people's expectations. So if I come with a sore knee to the clinic, I'm expecting that somebody will address that problem. I'm not necessarily expecting anything else to happen. Whereas in Kisisi, we would expect something else to happen. We'd be expecting quite a lot of checks to see if there are any other problems that we can help with before they become more serious. So there are different dimensions which, if we just ask the patient, did we meet your expectations? She might say yes, even though we would say the service, if we hadn't done all the things that we felt we should have done. So how it's measured and the interpretation, but also that feedback loop to make sure that the measurements then lead to change according to understand where are the gaps, what can we do. Thank you.
Thanks, Ian. Shane, any further comments on the downside of measuring compassion?
I think maybe I'll just answer Ian's question, because I think what he's speaking about is response bias. So obviously, when it comes to the SEQ and these measures of compassion, it's really important who's actually administering the measures. So if I, as the spiritual health provider, chaplain, is handing the paper to the patient and sort of sitting in the room and waiting for them to fill it out, that's going to influence it. So we recommend that it be an administrative person, a manager, a unit clerk, somebody who's not a part of the actual care team. So I think in your example, Ian, of using teachers would be a perfect example. I think, in terms of the downside is, and maybe this is to Sham's earlier point around sort of like measuring being linked to improvement and vice versa, is that, you're sort of measuring compassion at one section of the pipeline, if you will, at this stage in terms of the patient, at the bedside. And so, you become focused on that, but you don't recognize upstream and downstream that there's these other factors within the system that are actually causing, the effects of which are being seen at the point you're measuring it, because you weren't measuring it before, but now you're starting to see these things. So I think that's one thing. And I just think there also is a potential downside. I don't know if there's a downside to measuring compassion per se, but I think there's a downside or a caution to interpreting the results of these measures, as I was just mentioning. Again, these tools don't infer causation, and we don't know, why these things happen. And so in one context, for example, we might find like compassion seems to be, on this particular unit scoring really, really highly. The example that I like to use is you could be cared for by a not so compassionate labor and delivery team, but you get good news at the end of that hospital admission, you get a baby. But a really, really compassionate palliative care team might actually get lower scores because the news which they're delivering and the circumstances. So that is more of a thing of us being careful of how do we interpret these scores, and not sort of suggesting that team A is more compassionate than team B. So those are some of the things that come to my mind.
It feels to me, Ashley, the question is like not whether or not. It's more, this is a new area of discovery, and where do we start? And my suggestion on that is one parameter that I would be high on my list of things to consider in terms of where to start is, what are the pockets of our health system where that are really sensitive to compassion, where there might be, for example, a lot of stigma. So moms and newborns, HIV, TB, these care pathways, there's a lot at stake in the relationship between the provider and the patient. Whereas, it would be nice if I had a compassionate person giving me my COVID immunization shot. It would be nice if I had a joint replacement surgery, but those aren't places I would start.
That's an excellent point. And
mental health would be a key area as well.
Definitely. With that, I'd actually like to invite Shams to join us and perhaps piggyback on what's been said, and also answer or ask rather another question that may be on your mind.
Thanks very much, Ashley. And it's really been a privilege to listen to the rich input from all the panelists and all of the questions that came through as well. So maybe just bringing back this linkage with quality of care. I think many of the colleagues on this compassion rounds will know about how patient-reported outcome measures and patient-reported experience measures are often thought of as part of an overall measurement approach to quality of care. And coming back to this point about measurement and improvement being really closely linked, it would be really helpful just to hear from the panelists on thinking through compassion, and speaking to Chintan's point just now as starting points for measurement. What practical advice might you offer as a first step for those that are on this call? And not just an area, but actually what would be the tangible next steps that colleagues might even experiment with as they think through and develop their approaches to compassion measurement for improvement at the facility level? Because all of you have had such experience in this in different settings. It would be really helpful to hear your thoughts, and maybe starting with Shane and then moving to Ian and then coming to Chintan. Shane?
Yeah, and I have to confess, I'm a budding systems thinker, and so I think I'm sort of stuck at a microscopic level sometimes of really sort of dissecting what compassion is. I like to think that, at a clinical team level, there is some value in sort of putting some of these measures to the test in terms of actually seeing, does this improve care, for example, in a hospital type of setting, and for a hospital administrator to be able to sort of not simply look at those reports, but if they cared enough about it to actually, okay, how can we improve, the care that we're providing here, and how does that look different from last month in comparison to this month? Like, I think there is something organic, if you will, that is sort of ready on the ground. I'd like to think that, that we could also advocate at a more sort of system or national level for including metrics related to quality care and compassion in a more meaningful way. Again, professing that I'm not an expert in how those sort of things flow, but I do know that, patients, in terms of what they consider to be quality care, it often has to do with things that are related to compassion. And so if, again, we're taking that patient voice, the patient experience seriously, I think that's an inroad to have patients, advocating. But I really do feel that it needs to move beyond the individual healthcare provider patient to a systems level. But again, I'm going to plead some ignorance in terms of how that particularly happens. But those are some of the ideas that I have, Shams.
You're very humble, Shane, and no ignorance needed to be pleaded there. But thank you so much, Shane. Ian, to you, and then coming to Chintan.
Thanks, Shams. I think I'd start by asking people, are you part of a team? If you're part of a team, how often do you meet together? Who comes? Is it multidisciplinary? And do you ever have patients there? We found that with the insurance scheme, having the executive with whom we work and the group leaders is really helpful, because they're very motivated, they want it to work, but they're also very honest about any shortcomings and any positives. So that gives us a finger on the pulse of what the people are thinking. And as I said earlier, it's often a reflected response in that they've had time to digest and think about. So if I think back to my admission 6 weeks ago, I may reflect a little bit about the overall care. So I think that's been quite an interesting one. Have you got a team? How often do you meet? What's the agenda? Does everybody have a chance to contribute? Because if you share those things, and of course the overlap is clear between quality, as Shams said, compassion, patient safety, universal health coverage, all these different areas overlap. You're seeking to do all that as well as to be efficient. Yes, you have to be sustainable and efficient as well. So those interactions are the time challenged where there are gaps, and together come up with ways forward. So that would be one suggestion. Thank you.
Very practical, Ian, as always. Thank you. Chintan.
Yeah, have the first conversation. And what that looks like is, whether you're at the global level, a national level, even a specific facility, get a group of people into the same room. And that group, in my view, should have a patient advocate, a frontline provider, and somebody with this payer perspective. And by showing up, they've expressed that this matters to them. And then the conversation should be equal parts of two things. One is, what's a self-assessment? It doesn't need to be a metric. It could just be a subjective self-assessment. Where are we doing well? Where could we improve? And then the second half of the conversation is, what are some practical things that we could start doing now? And if you keep having those conversations, you'll end up probably with some great metrics and some great systems in place. But get the right people in the room and have a first conversation.
Very clear, Chintan. And Ian wants to add a point, I believe.
Yeah, just picking up again, one thing that we found quite interesting was this thing I raised about time, that asking the question, is what we do at 3 a.m. the same as at 3 p.m. is quite a good provocative question in a whole range of areas. So it's a good one. It stirs up a lot of thinking and response. Thank you.
And globally, anywhere on the planet, that question would be very, very relevant. Absolutely. Ashley, turning back to you.
Thank you, Shams. Yeah, I think we'd be remiss to end our conversation today, and I'm sad to see that we only have a couple of minutes remaining, but something that really rose to the top in so many of the comments we received from the people who are here today listening in is questions around measurement across different contexts. So thinking about things like culture, even thinking about public versus private facilities, things of that nature. And I'm not forming this very well into a question, but I wonder if you might just comment on how to be thoughtful about measuring and enhancing compassion while being attuned to some of the differences you might see, whether it be at a facility or an organization or within a system. And Chintan, I might start with you, simply because I know Leapfrog to Value works in so many different contexts, and certainly it's something maybe you've come across or you've had to think about. And then from there, maybe Ian, and wrapping up with Shane.
I'm afraid I didn't totally get that question, Ashley.
It's probably because it wasn't a very well-formed question in of itself. I think, so many people said, I know that there are measures for compassion, but, and I'm certainly, we've come across this in our own work. They're validated in Western contexts, for example, or are there tools that I can be implementing that are shown to work across different cultural contexts? Are there things that I can be thinking about in a public versus a private facility, for example? I mean, I think you've been pretty clear in your approach is that you get the right people in the room and you have the conversation and assess what we're doing. But I just don't want to end the conversation today without at least spending a moment on this concern of sort of cross-cultural compassion and how to think about compassion in many different contexts.
Yeah, it's a great question. And I would say that the purpose of having the patient advocate and empowering that patient advocate to really be a credible voice in the room to sort of push back when a proposed questionnaire, for example, is not going to land. That's why that person's in the room, and the responsibility there is making sure that whatever is sort of asked is going to resonate. So maybe I'm not really offering anything new there, but
no, it's a helpful point, and the role of that patient advocate is crucial. So thank you for pointing that out again, Ian.
I mean, respect and dignity and the value of each person goes across the globe, doesn't it? It's not restricted to one place. And I think it is very much about motivation of your team and the leadership approach, what they're prepared to invest in, how it's set up. We, for example, have our chaplains are on call at night. So at 3 a.m, as in response to that question, they are available to come in and give extra support when the doctor may be very busy, like with the child I showed you who was very septic. We still have that support for the family who are worried about their patient and so on. So trying to see what works in your local setting is where your teams have to contextualize the principles and then apply them in practice. So I think that's what the teams should do. They need to know the different factors, what else is around them, and then agree this is the way we can best make this happen on the ground. Thank you.
Thank you, Ian. Shane.
I think, yeah, just to reiterate a bit of what's been said already, I think number one, on Ian's point, I do think compassion is a universal construct that traverses cultures. We know that from some of our research. However, having said that, I also think we need to make sure that those measures have been actually validated within those contexts, because certain nuances of compassion, I think, seeking to understand in one culture might be seen as something that's sort of an affinity or a thing, and in another culture it's invasive, and I'm being very broad in those generalizations, but I think we need to make sure we do that. I also think, I think it was Ian as well who made the point around expectations earlier. And I don't know whether other cultures have, lower expectations of compassion, certainly, but I think I can say from our research that we have noticed that other cultures often have a greater appreciation for compassion than some other groups. And so, for example, an immigrant to Canada who's coming from a healthcare system that is private, that they can't afford, they come to Canada, they get public healthcare. They're pretty happy with what they're getting. So we just have to recognize that there are some cultural variants that I would say that that is at play. And so I think I probably just end my comments there for in light of time today.
Yeah, thank you, Shane. And I think for those of us who are trained as researchers and scientists, I think this question is an important one in terms of the validity and reliability of certain measures across contexts. But Ian did a wonderful job reminding us about the central tenet of compassion, which is that shared humanity, and that desire to be treated with respect and dignity really transcends all kinds of boundaries. Please forgive me for going over time today. Thank you so much for the wonderful contributions from you all as our panelists. And Chintan had to drop off quickly for another call, but my thanks extends to him as well. And also to all of you who are still on the call as participants. Thank you so much for joining our conversation. Thank you for your thoughtful questions. And I very much look forward to having you all join us for the next quarterly rounds, which will likely be in December, but stay tuned. And with that, please do reach out to us should you have any questions, and be on the lookout for a report and a recording of this rounds that you can share with others. And please feel free to also email us with any other questions you may have, or if you'd like to connect. Thank you so much. And I hope you all have a wonderful rest of your week.